And so what happens is chemicals build up. Nitric oxide and calcium gene-related peptide builds up in the brain. And when that builds up, those chemicals are chemical messengers that actually cause vasodilation. And so that's building up. And we're consistently bombing, sending messages down to the lower brainstem. Please get these blood vessels to dilate. And what happens is when it finally reaches threshold, that the lower brainstem sort of kicks in and fires, it overfires. And now what happens is the blood vessels overdilate. And when they overdilate, what happens is the nerve mesh that surrounds the blood vessels, which are heavily laden with pain nerves, they stretch. And bam, that's when you develop your migraine headache. Okay? But the reason why it occurred is because the lower brainstem wasn't working fast enough. Its frequency of firing was not efficient enough to meet the demand for the oxygen. Okay? So that's the one reason why patients get migraine headaches. It's a neurological problem. Okay? The second reason is due to the fact that frontal lobes may not be firing well. See, typically what happens is the back part of your brain is called the sensory part of your brain. That's the part of your brain where your sight, your sound, your smell, your vision come in. And normally when that information comes in, the parts of your brain are sort of overstimulated, and then they send messages up to the frontal lobes. Well, the frontal lobes send messages back to the lower, back to the back part of the brain and sort of calm it down. So if you're really working real hard with vision, your occipital lobe's going to fire faster. Well, the frontal lobe sort of says, calm down a little bit. You're overworking back there. Ease down. You don't need to work as hard. Well, if somebody's brain is not firing properly in the frontal lobes, not that they have a stroke, not that they have a lesion in their brain, it's just that an area in their brain is not sort of doing the job. It's not as efficient as it needs to be. Well, guess what happens? The demand may increase, because what happens is the frontal lobe is not slowing down the occipital lobe. And so what happens there is it makes the demand higher. Well, if the demand gets higher, and this already doesn't do a good job at meeting the demand, bam, you get migraine headaches. Okay? Now, the other thing that happens is the lower brainstem slows down the upper brainstem. They're sort of like yin and yang. If the lower brainstem is doing a good job and working the way it needs to work, then the upper brainstem will be slowed down. And again, it's like an unruly teenager. It creates a lot of problems if it's going too fast. So lower brainstem slow, upper brainstem is going fast. The upper brainstem affects what's called the sympathetic nervous system. The sympathetic nervous system, when it's firing too fast, creates inflammation in the body, and it also affects pain nerve endings, which makes for sort of a fertile ground for these headaches to occur. So to affect somebody with migraine headaches, you need to treat them neurologically. Now, when the migraine happens, it's not always just in the back of the head, because what happens is you get cortical spreading depression, which means the blood vessels are affected all through the brain. And that's why that migraine, sort of you get that prodrome, that sort of strange sort of aura, and then bam, suddenly you've got this ice pick in the back of your head, because it really affects all the blood vessels. So decreased firing lower brainstem, decreased firing cortex, sometimes a decreased firing cerebellum is the cause of migraine headaches. We're going to talk about the treatments and how we determine if this is occurring in your body. It usually happens due to long-standing stress, chemical stress, which could be either poor metabolism or poor hormone access, or it can also be caused by physical stress, which affects the structure in some of the joints in your neck. Now, let's talk a little bit about tension headaches. Tension headaches, or cervicogenic headaches, happen when certain parts of your spine are not in good alignment. When you look at somebody's spine, the spine should be very straight from the front. From the side, you need to have three curves, one in the neck area, mid-back, and low back. And you can see that right in through here. One in the neck, mid-back, and low back. Well, as patients or as people with tension headaches go to work and they sit in front of a computer all day, they can start to lose the normal structure in their neck, or they may have a car accident, or they may have had sports injuries, or poor posture. Well, over time, when you have this poor structure, what it does is it starts to put pressure on all the joints in the neck, and it starts to irritate free nerve endings in your neck. Now, those free nerve endings are pain nerves, and what they do is they send messages into your spinal cord. And they go to an area in your spinal cord that is right next to what's called the spinal trigeminal nucleus. And the spinal trigeminal nucleus, the trigeminal nerve controls pain and sensation in your head. And so what happens is that spinal trigeminal nucleus goes all the way down into the neck area. And so they're right in the same neighborhood. And so if you have loss of curve or poor structure in your neck from poor ergonomics at work, or car accident injuries, or falls or slips or strains, or you've got poor joint health in your neck, what happens is those pain nerves come in, and they not only stimulate nerve endings that could cause you to have neck pain, but they can go in and actually stimulate the spinal trigeminal nucleus. And the spinal trigeminal nucleus causes head pain. But here's the problem. The pain is actually not being caused by damage to your head. It's being caused because there's poor alignment and poor structure creating pain nerves coming in, and it's irritating the nucleus, sort of the neighbor, so to speak. And so you may have no neck pain, but you may get headaches from a problem in the neck. Okay? And if you look at the x-rays that I'm going to put on the video right now, the x-ray on the left is somebody that has lost the normal curve in their neck. You can see that there's some pressure in some of the discs. The discs are the spacing that you see there, and you can see that the spacing is sort of narrowed. This patient had migraine headaches when they came into the office, and through a course of care, we restored that arc, that structure in their neck. And they didn't have migraine headaches, they had tension headaches. And if you see there, the headaches, I mean the curve is actually really nice in the neck now, and their migraine headache, their tension headaches are completely gone because we improved the structure in the neck, which took the pressure off of the nerves going in, and their headaches went away. Okay, so that's tension headaches. So what I'd like to do now is I'd like to show you some of the treatment modalities that we use, the neurological treatment modalities, and describe the exact neurological exam that we do. So I'm going to take you into one of our treatment areas to discuss that. Okay, what I'd like to do now is I'd like to talk about some of the specific neurological testing that we do in our office. I'd also like to talk about the specific neurological brain-based treatments we do for patients with migraine headaches. Now when somebody comes into our office with migraine headaches or tension headaches, we want to test them neurologically. We want to test them metabolically, which means we want to look at their blood work. We want to look and see how well their hormones are doing. We want to look at their adrenal glands, and we're going to talk about that in a bit. The other thing we want to do is we want to look at them biomechanically, which means we want to look at their spinal joints. We want to look at the health of those joints. So let's talk about the neurological testing that we do, which is specifically important for patients with migraine headaches. Now we do the standard neurological exam, which is, we're going to look at reflexes, we're going to look at pinwheel, we're going to look at vibration, sensation, we're going to test your muscles to see if you have strong or weak muscles. Basically the average neurological exam. But the other thing we want to do is we want to look at you from a functional perspective. Now, if you recall when I was talking about the cause of migraine headaches, we talked about the cause being a lower firing lower brainstem, which is called the pontomedullary area, or a decreased firing of the frontal lobes. Now, as human beings, we are the only species that have certain attributes on certain sides of our brain, which means that we have a left and a right side of our brain that perform different functions. So in our exam, we want to look and determine how well your brain is firing from the left and the right side. We also want to see how the lower brainstem is firing. We want to see how the upper brainstem is firing. We want to see if it's overfiring. So we're going to do a specific exam. One thing that we look at very heavily is we look at your eye movements, and we look at your pupils. It's been said that the eyes are the window to the soul, but it can be also looked at as that the eyes are basically a very good window into how your nervous system is functioning. So we're going to look at your pupils. Patients that have a larger pupil on one side versus the other side, that's typically indicative of a right hemisphericity, or a brain that's not quite firing as good as it needs to be firing on one side.